Okie dokie. Let's get started. So thank you everybody for joining me for another one of our specialist educational seminars. Today we have Dr. Tamara Culnane, who, in case you noticed the surnames, is actually my sister. She's already done another seminar with us on medical terminology, which has been viewed several hundred times since then. It was actually a really good seminar. I hope that this topic will be equally as well received. It's certainly a very topical topic in what we're beginning to see in our growing medical negligence practice, but even in other matters where people have complications in workers' comp surgeries and things, the question of how anaesthetic is administered, chosen, and how it works is really, really something that people don't know about. So I will hand over without further ado to my sister. Can I ask that you all keep yourself on mute, please? The reason for that is so that noise from your workplace or home doesn't interfere with the quality of the recording. At the end of the session, there will be the opportunity to ask questions. If you have to go before the session ends and you have a question, please type it into the chat and I'll make sure that it gets answered and that Dr. Culnane answers it for you. Also, the recording should come out to you by the end of today, but it might be on Monday. And also the slides will come to you at the same time. And of course, all of our recordings are available to you on our YouTube channel, which you can access by Googling Medico-Legal Assessments Group YouTube. But also, if you have a Mag Connect login, it's on the left-hand side in the menu bar under the word seminars. Anyway, thanks so much. Over to you, Tamara.
Thanks, Mish. So good afternoon. I hope this will be helpful. I'm concentrating today largely on the sorts of anaesthetics we give and how we choose how to get which one to give, rather than the risk factors. I will be touching on that, but I hope it will demonstrate that anaesthesia is a moving feast. It's a titrated, considered thing. And that we have to be on our toes and prepared to revise our plans at any time. So anaesthesia basically has a purpose, and that is to provide conditions so that surgeons can do the operations they need to do, because these things could be painful or distressing. And also they involve deranging or changing our physiology by clamping blood vessels or opening body cavities, altering the way the lungs and the organs would function, etc. And so we're there to provide conditions that will render a patient cooperative and not unduly distressed if they're actually not asleep, and otherwise unable to resist or move in a way that's going to cause a problem to a surgery, such as when a microsurgeon is reconstructing a nerve or a blood vessel. We want things to be very, very still. And so we do that by sedating people or making them sleepy, or perhaps by paralysing them in addition to that. We also want conditions that make the patient stable to the insults that are coming at them, and that might be the insults of underlying disease, conditions, trauma, etc., as well as the effects of the surgery, such as shifts in their fluid balance, bleeding, and so on. And also we need to deal with the side effects of our anaesthetic drugs in order to keep the patient stable. Also, we've obviously got a big role in deciding how to provide pain relief, both during and after the procedure. So you can categorise anaesthetics in a number of ways. This is a useful one: monitored care, and that's hand-holding. We do a lot of that, even when we may have also administered something like a local anaesthetic or a blocking technique. And that's supporting a patient to have a procedure with supervision and being a standby backup in case the patient needs you to take some more control with some sort of sedation or general anaesthetic. Local anaesthetic, we're all pretty familiar with having an injection to have stitches or something like that. Regional anaesthesia, which is local anaesthetic but used in a larger region of the body. That could be a spinal injection, an epidural injection, which can numb your body anywhere from the mid-chest downwards, depending on the level of its insertion and your doses. It might be something called a Beers block, where cannulas are inserted into your arm so that we can infiltrate local anaesthetic into your venous system with a cuff to stop it going to the rest of your body, so that we can induce the common elderly lady's wrist fracture. I've mentioned spinal epidural block. It can also be a plexus block, so that you can numb the arm from the armpit down or the elbow down, or likewise the leg. Then there's sedation or twilight anaesthesia, and of course general anaesthesia. And as mentioned, both of those last techniques have often got a local or regional technique combined with them for analgesic purposes. So local anaesthetic, to make you numb, it generally is only acting on the sensory nerves or fairly superficial regions. So it's suitable for small procedures. You're not going to get someone still, and you're going to have someone that's got to be aware and willing and cooperative to have that. So it's not always that easy to do it, to stitch up little lips and fingers in small children, etc. Also, if you're having a procedure without sedation or without significant sedation, you're going to be aware of things that are happening in the theatre. You're going to be aware of the clanging of instruments and other noises. If there is diathermy or electrical cautery used, which there often is, you'll hear that buzzing and you may actually smell that. And of course, people worry about seeing blood, but generally we're going to have a screen so that someone doesn't need to actually watch that. It's really safe, obviously, if you're cooperative. It's a great thing to do. You can, unless your hands and feet are involved, you can drive and do everything you want to do for the rest of the day. You don't need to be fasted. So there's so little disruption. It's obviously not for everyone. Problems with local anaesthetic. Allergy is actually quite rare to local anaesthetics. Obviously, people might be needle phobic or have a faint in association with the sensations there. And duration can be a problem. If something's fiddly, you might have discomfort as time goes on, need to top that up or need to do something else. So regional anaesthesia is a wonderful technique. Obviously, it can be combined with sedation or general anaesthetic. And you're generally injecting your local anaesthetic around larger nerves, so not just cutaneous or sensory nerves. So you're often going to get paralysis. So you're going to get a still limb or a still bottom half of the body. Nerve blocks, plexus, so the cervical plexus, the group of nerves that go to your arm, or your lumbar sacral plexus to your leg, and those can be inserted through your armpit, lower down in your elbow, or injections in your back or in your groin. Again, if you're using that as a technique in an awake patient, they've got to be game to have a little bit of discomfort and so on as you're preparing and doing that, but it can be done with fairly minimal discomfort. And of course, spinal anaesthesia, injecting your local anaesthetic into the cerebrospinal fluid right around the spinal cord, gives you quite a dense paralysis and sensory block. And an epidural, such as we use for labour, epidural, and we also use it for things like hip and knee replacement, where we insert a catheter into your back outside the spinal fluid where the nerves are leaving, and we trickle anaesthetic in there. And so you can have quite a long duration of both anaesthetic and then pain relief with an epidural catheter left in situ. Problems with regional anaesthesia, well, it's not just a local. Once you actually are injecting larger volumes of anaesthetic around bigger nerves, you get physiological changes because part of your nerve bundles have sympathetic and parasympathetic fibres, which are the fibres that peripherally alter things like your venous tone. You can have absorption from very vascular areas where you have the local anaesthetic significantly absorbed into your circulation. And if that gives a significant peak, then you can have toxicity. And the local anaesthetic's toxicity consists of neurological, which can be tingling, tinnitus, and leading on even to things like seizures, and cardiovascular effects, which is cardiovascular depression, and that can be cardiovascular collapse and arrest if it's severe. There is obviously a grading and a level at which we think that we're quite safe with the sort of doses that we're administering, and it can be carefully calculated, but it's always in the back or the front of our minds. When we're doing a regional technique, they're often done what we call blindly, in other words, without any guidance by an X-ray or an ultrasound. And I was taught in the olden days to do all my blocks, whether it be in the neck, the chest, the back, without an ultrasound. For a lot of blocks, ultrasound guidance is now best practice and has really increased safety. But you can't use that when you're putting an epidural in someone's back. That is a blind technique. And there is a very large needle called a TUI needle. It's about this big. It's quite thick, about as thick as the lead inside a pencil. It's a hollow needle through which we feed a catheter. So that could do damage. And it is quite a technique to make sure you feel that you've got in the right space. It's millimeters of leeway. Also, if you're injecting into deep structures close to large blood vessels or even small blood vessels, patients on blood thinners or with their own bleeding problems are going to be at significant risk. And if you bleed into a confined space around your nerves or in your spine, then you have pressure effects and the potential for neurological damage. As I mentioned earlier, you do get effects on your sympathetic and parasympathetic nervous system, and that usually causes a drop in blood pressure. There are some valvular problems and heart problems, such as aortic valve disease, where a general anaesthetic, even in a person with quite severe cardiac disease, will be far, far safer than a regional technique. And when you're doing an epidural for a woman in labour or having a caesarean, you're going to affect the maternal blood pressure and therefore the placental blood flow and therefore potentially the baby. And so you have to be prepared to be very vigilant and titrate that carefully. So the regional techniques really require training and familiarity. I don't do much orthopedic anaesthetics anymore, so I haven't done a neck block, a cervical plexus block for some years. I do a lot of axillary blocks and other blocks for arm and leg surgeries, and I'm quite familiar with them, and I've upskilled to be proficient using an ultrasound. And in fact, I wouldn't do it without one unless it was an urgent thing and an ultrasound wasn't available, because ultrasound guidance gives you a wonderful two-dimensional picture of where you're putting that very big needle. However, you know, some of us are dinosaurs. Now, sedation aims to make a patient comfortable without resorting to general anaesthesia, and the college, ANSCA, has guidelines and professional documents which talk about all of these things and talk about the particular depths. So, you know, minimal sedation, you have quite a cooperative patient who's basically just feeling more relaxed. Once you start to get to a level of moderate sedation, you might have a responsive patient, but there's the potential for them to be perhaps disoriented or not as cooperative as you'd like. When you go to deep sedation, essentially you're bordering on a general anaesthetic. You've got a patient that's not easily roused, and at that point you can start to get problems with your sedation depressing respiratory functions like airway openness and breathing and the cardiovascular system. There's a big issue, I think, in the way anaesthetists consent for sedations. It's a bugbear of mine. I always discuss awareness when I'm doing sedation. So if you're coming to have your colonoscopy, endoscopy, that sort of thing, or your skin graft, I say, you might actually speak to me or remember me asking you to take a deeper breath. You'll be particularly comfortable when we're injecting local anaesthetic, et cetera, but you may have lighter planes of anaesthetic, and I'll have you very comfortable. And we need to make sure that people are okay with that, because it's common for us to see in the medico-legal sense people who feel that it wasn't made clear that they might have some awareness, and people need to know that. There's often a perception that sedation must be safer for my child. You won't do a general for their broken arm or their other minor injury, etc. Sedation will be safer. In fact, children, for a lot of other reasons, which I won't go into in great detail, are actually much more difficult to manage under a sedation unless they're much older children or teenagers. And generally, the best thing is a secure light anaesthetic for a minor procedure, general anaesthetic for a minor procedure in a child. So general anaesthesia, if you want to define it, it's controlled unconsciousness. And we talk, when we're using anaesthetic gases, about the minimal alveolar concentration, which is a way of dosing. They took cohorts of people, got them off to sleep with gas and measured and kept them at certain staggered levels of gas in their bloodstream. And then they cut them on the forearm without any local anaesthetic. in a stereotyped way, and they counted how many in each group moved. And that's how they decided on a Bell distribution in the population of how much gas you need to be well enough for sleep. And so we titrate these things, and there's a fair amount of accuracy there, but nonetheless, there's population variation. General anaesthetic drugs on their own, without all the other bells and whistles I'll talk about, are a pretty blunt instrument. So they alter your consciousness, but it's not a normal sleep state. So your respiratory and cardiovascular function, which are controlled in your brainstem largely, are going to be affected. Those neurons will be affected as well. And so we're going to have to support people more to have an open airway, because the airway muscles are often the first to relax, and to breathe if they're not going to breathe deeply enough or well enough, and often to breathe if we've had to paralyse them, obviously. And also blood pressure derangements, mostly down, often up, and alterations to heart rate and conduction. So we need to have an armamentarium of things to deal with the side effects of our own anaesthetic drugs. Obviously, general anaesthetic is going to be mandatory for significant procedures, and it's going to be given as a combination of other things that are adjuvant. So pain relief, you might give something relaxant so that people are not too anxious as you're getting them set up. And all these things have additive effects on things like the ability to breathe for yourself. Basically, the two groups of general anaesthetics are the inhaled ones I've talked about, and some injected medications, the most common being propofol, the drug that killed Michael Jackson, which is so safe if it's in the right hands in a monitored situation, and they're going to stop your conscious awareness of pain. They're not necessarily going to prevent movement to a painful stimulus. So for quite significant procedures, even with a lot of anaesthetic and a lot of opioids such as morphine, we may need to actually paralyse you. In general anaesthetic, one of the ways to define it is that it's an anaesthetic where the airway is secured. So if I'm giving you a sedation, I might assess your airway and you physiologically as being likely to maintain your airway quite well. That might change. I may need to give you some jaw support or positioning, or put a small plastic airway into your mouth or nose to keep your airway open while you're sedated. But in a general anaesthetic, you're always going to secure the airway, and that might be with an endotracheal tube all the way into the trachea through the larynx, or with various other upper airway devices such as the laryngeal mask, which is a funny big flange that just sits on the top of your larynx at the back of your tongue. So there are a range of techniques according to whether we've had to paralyse or not, according to the depth we need. We might have a patient who's under general anaesthetic spontaneously breathing. We might have someone who's intubated and ventilated. The decision-making is complex, and often for a certain procedure in a certain patient, you can argue for any of, 4 or 5 techniques quite easily. We make our decisions based on absolute requirements, in other words, certain neurosurgeries, abdominal and thoracic chest surgeries. Again, things like patient preference, we would always take into account if we can. For a local anaesthetic procedure, some may have experience, they may be willing to be aware, they may have had experience of the needle being too uncomfortable or feeling faint. And people often present with their own beliefs about safety, as I've discussed, with the distinction between a sedation and a general anaesthetic, which need to be addressed so that your patient is comfortable with what you're advising them, or is comfortable with the choices if you're advising them that they have more of a choice themselves. Obviously, there are surgical preferences and requests and other parameters. And when I'm giving a sedation for endoscopies and colonoscopies, if I'm giving that in a public list where there is a more junior doctor being trained to do those procedures, we might do 4 cases in a half day. If I'm doing that in other settings with a skilled endoscopist, it might be 15. And so my recipe is going to vary quite a lot. Those people need to be kept safe and comfortable, and I'm going to give quite a different spread of medications for the longer cases. So those things, all of those decision-making parameters are often going to contradict each other a little, and then we have to then make either a prescribed decision or, as I've said, a recommendation or giving some choice. Whatever we do, we have to be prepared to escalate and be prepared for complications of whatever has brought the patient to surgery, be it their underlying cancer, trauma, infection, appendicitis, etc., and what the surgeon does in terms of bleeding, traction on nerves and other things, and what we're doing with the side effects of all our drugs, as I've mentioned. I'm going to go through a few cases now and just sort of talk a little bit of a cook's tour about what one might do. So Mr. NG is an older man and he's got a significant scalp skin cancer, and he needs a wide local excision of that, and a local flap is going to be rotated into place. That involves excising wherever that lesion is, mobilizing and loosening the scalp, and bringing that together to actually give coverage to that wound instead of taking skin or tissue from somewhere else to cover that defect. That sounds Frankensteinian. It's actually quite a good operation, surprisingly good cosmetic results. What could we do? I could let this man have local anaesthetic and just stand by and chat about the cricket. I could give him a sedation, just stunning him at the point when that local is being injected in. Your scalp's quite sensitive. It's a sore spot to have local injected, like a finger or a lip or an ear. And say to him, I'm going to let you just lighten up after that. And if you're oriented and comfortable enough, we can just chat. If you're at all uncomfortable, I'll keep you in a deeper plane of dosing. And then I can do that. And if I can manage that well with my surgeon, and then we have a patient that's cooperative enough, that's great. A great way to minimise the cumulative anaesthetic dose for this gentleman. I could sedate him throughout, or I could give him a general anaesthetic, and I might be more likely to do that if there are certain issues, if it's going to be quite a long procedure, if from the get-go I think this person won't be able to cooperate, or if I've made an assessment that they've got characteristics of their airway, so their mouth, their teeth, their jaw, and their neck and so on, that might make rescuing an obstructed airway in the middle of it difficult, then I might want to secure that from the start. So let's imagine he's really well, he's cooperative and willing to have a local, he's got bowls and other stuff on later, fine. Or he wants a bit of sedation, fine. Or he's unwilling for any sort of awareness, won't be dealing with that. But with some discussion, he's happy for me to titrate a light sedation. If he's refusing to have any awareness at all, then I can go to those other levels and I can decide whether he'll in fact need to then stay overnight, etc., depending on his social circumstances, the time of day and so on. So then we're modifying our whole management. If he's quite frail, then I'm going to be more didactic. I might, if I feel he's quite oriented, lean on him to just have local with support and standby. He may be more unwell with some significant dementia, or he doesn't hear well as well and his hearing aids were left at the nursing home or at home, or he's frankly confused. What if he becomes combative and uncooperative and pulls at the drapes? Titrating a sedation is a little bit more difficult in elderly people, particularly with cardiovascular disease. It's slow to circulate. It's a bit harder to titrate sometimes. And again, I don't want to be intervening with an airway problem in the middle of a sterile procedure. So sometimes even for this more frail patient, I might actually escalate from the beginning to a general anaesthetic, which sounds counterintuitive. But if I'm doing that, I've got a secured airway. If I've got to position him on his side or lying supine when he might have otherwise been breathless, or he's got back problems, kyphosis, can't lie flat well, I can secure him from the get-go. I can titrate that carefully. And once we're in position, run him at a very light level of general pretty safely. There are potential other issues with that in terms of post-operative confusion. It's controversial in elderly people with cognitive concerns as to whether sedation or general anaesthetic, or even, for instance, a spinal anaesthetic for a procedure has much differential in terms of post-operative delirium and those sorts of problems. But sometimes it's nice to avoid a general anaesthetic. So again, just to look at sedation in general, we've got total control from the start with our general. However, the induction of a general, particularly placing an airway, particularly placing an endotracheal tube, causes more disruption to breathing. There is often cardiovascular effects of our induction drugs that are actually more severe and more trying and more taxing on someone with comorbidities. But we're less controlled if we're starting with a sedation, and you really need an apprenticeship to titrate sedation. I think it's a harder anaesthetic to give a lot of the time than a general anaesthetic, and there's very little time to be sitting down and reading your gardening magazine. You're really, really focused when you're doing a sedation. So let's look at Ms. BG. She's a lovely 19-year-old student, and she's got a mole on her forearm which bothers her. It's not changing. It's not thought to be malignant, but she just wants it away, which is fine. So she's going to have an excision of that lesion. It's lovely to get people having these sorts of things to have a local anaesthetic. Unfortunately, it's not for everyone. She might be needle phobic or just anxious. She might be worried about hearing and seeing what's going on. What are my options? I can offer her a bit of oral anxiolysis, so Valium and similar things. It might not turn out to be enough. She might actually be a bit disinhibited and uncooperative and become more anxious with that, leading me to escalate. We do have local anaesthetic gels, which you might have seen used either for yourself or for a child, that we can numb your skin with a bit before we put a drip in. And we can actually do that over a small lesion. And I often do that for teenage kids having a small skin lesion. Put the gel on under a dressing for about 45 minutes, coach them through having the local in, and they'll feel a bit of pressure and mild discomfort at the most. And then if they're up for it, they don't have to have any sedation or general. However, again, that's not for everyone. Not everyone will cope well with that. Then there's intravenous sedation, which if she's a fit young lass, I can titrate to the tolerance that we've agreed. But if she's perhaps very obese girl with obstructive sleep apnea, unfavourable looking airway assessment, I don't want to get into trouble with a sedation, an obstructed airway that's difficult to instrument, and that sort of thing. And then we've got movement, drapes have to be pulled away, etc., etc. It's a bad look. And so I might actually go straight to a general anaesthetic for a procedure as minor as that, if it seems to be the best thing to do. So Ms. KL, she's 39 weeks pregnant, but unfortunately the baby is not oriented quite well, and she's been labouring for a bit. It's pretty obstructed and she's not looking like she'll deliver vaginally. And now the fetal trace is looking unfavourable. In other words, there are decelerations in the baby's heart rate in response to her uterine contractions, and the obstetrician and midwives are saying she's not going to deliver well and the baby's now a bit unhappy. So we'd then bring her down for what we'd call a category 2, urgent but not totally emergent caesarean section. What am I going to do for this lady? If I give her a bog standard general anaesthetic, the volatile gases and any other things I give her are going to circulate pretty quickly to the placenta. I mean, I can do that. But if I've got a good regional technique, it's much better for the mother. It reduces her risks of things like problems with her tube, aspirating gastric contents, which is common in pregnancy and at delivery, and all sorts of other complications that are specific to pregnant women. So I'd like to do a regional technique if I've got time. If she's got a working epidural, I can pretty rapidly, within 12 to 15 or 20 minutes, have her very, very numb from the waist down. She'll still feel some touch and pressure and stretch, and it's really important to explain. We often use the term, it might feel a bit like you're having the dishes done inside your tummy, but you won't feel cut or pain, but you'll feel them pressing on the fundus of your uterus, and you'll feel stretch as that baby comes out, a small bikini line cut. And you really need to coach that through, because you're asking women to go through something that's, you know, often quite frightening and in this urgent situation. Supposing she comes down and she's had an epidural put in because she was labouring so long, but it's a bit patchy. Now, the first thing I say when I consent someone for their epidural is it might fail, it might fall out after it's worked for a while, it might be one-sided, better on one side than the other, or it might be patchy. So if she comes down with a dodgy epidural, I want a good block for a cesarean section. If I've got time, I will remove that and put in another block, be it another epidural or a single shot spinal, which is very quick and very dense. If I haven't got those options, either there isn't an epidural to top up and the trace is worrying, then yes, I'll go to general anaesthetic. There are significant risks there. We also need to have the woman draped, prepped, disinfected, with the team standing gloved, scrubbed, ready to go before I give any drugs, because I want that baby out before a significant amount of anaesthetic has circulated through the placenta. So it's a challenging anaesthetic to give. Let's move on to something else. Mr. AT is in his 60s and he's got prostatism, so he's getting up 6 times every night to urinate, which is not fun for him, and he's going to have a transurethral resection of his prostate. The options here are either a spinal block or a general anaesthetic, and in the past, the techniques, the surgical techniques, the machinery was such that these could take 3 or 4 hours. Even if they were quick, there is a lot of flushing of the bladder to prevent clot, and that would dilute the sodium in the bloodstream of these men. And we liked to do a nice spinal for them because you could assess their mental state, because unfortunately, even intraoperatively, some of them would become confused as a sign of that low sodium, and they could even go on to have seizures. Another advantage of a spinal is when you wake up after a TURP, you've got a large catheter in which is still flushing your bladder, and it's dreadfully uncomfortable. And just early on, these men tend to be a little bit more comfortable, small advantage. Now with the current surgical techniques, it's a lot faster and the sodium complications rare. And so basically it's a matter of choice and appropriateness. If you've got certain significant heart problems, as mentioned earlier, significant back problems, if you're not going to be able to lie flat awake comfortably, then I'm going to go to a general anaesthetic because I can make you comfortable while you're asleep. Confusion and other issues in more elderly people are obviously a factor. So we'll go to a child. RT is 2 and it's finger versus door. So he's got an injury to his finger and the nail bed needs repairing, and it might need a little wire if they find that little end bone is fractured. As I mentioned, sedation is not a great idea, and generally we're going to give a general anaesthetic, and the only choice I've got here is whether I do it with an intravenous induction or a gaseous induction. At this stage, you're really going to want someone with paediatric anaesthetic experience. If you're an occasional paediatric anaesthetist, older children, you know, in the older primary school age and above, great. But for these guys, they're physiologically and anaesthetically quite different. An intravenous induction in a lovely chubby 2-year-old who's got a sore finger, they've been fasted, they're in a strange place where all these strange people are doing strange things to them, and they're already in tears, and their parent is already probably anxious, and you've got very good anaesthetic assistants trained with distraction techniques, holding techniques. Sometimes it's a lovely technique, but if it becomes difficult, then it's really no fun. And most commonly in a lot of these situations, we're going to give gas, and I'll put some lip gloss flavouring in a mask. And if they're an older child, we'll play with some stickers, but we'll sing to them, whatever it is. If they're still distressed with that, with a comfortable hold, good effective restraint, I can have them very stoned very quickly and reassure the parent that that's a reasonable thing to have done. Obviously, you talk to parents about that earlier so that they're aware that might happen. But this is a quandary because now I've got an anaesthetised child without a drip, and I'd never do that in an adult because I need that drip there to deal with the complications of having put them off to sleep. I might need to give medication, etc., etc. So there's a window there when I need that parent to be escorted out so I can do those time critical things, secure an airway, which I can often do without a drip being present, and get a drip in and some monitoring on. So it's a bit of a back the front way to do things, and it's a different technique, but it has to really be a general anaesthetic for this child. Now, this is a case of really a question of what we should do and what the boundaries are and how should we collaborate about these decisions. CG's 97, she's in a nursing home and she's really got significant dementia, and she's cared for by the same people because she's quite distressed with anything that's unfamiliar. Unfortunately, she was having a full hoist transfer, and she got a skin tear in her leg, which is quite nasty. She's on anticoagulants, which we might question at 97, but she's on them, and she's got this dreadful hematoma and leg wound. She's brought in, and she's really struggling, obviously, with the environment, and so are our staff struggling to make her comfortable. But there's a lot of pressure to do something about this wound. There's a lot of pressure from the nursing home as well as the family. Now, does she really even need to have an anaesthetic? And this is where we need to be collaborative and step back with our decisions and say, do we need to do this? Could she have dressings, long-term dressings for, what's called wound healing by secondary intention, where it slowly heals itself in a familiar setting with some analgesic given to her at that time by the people that know her, with some instruction. And that was suggested to her. Sometimes it's important to stop and think about what we're really doing. And there are a number of occasions when I've cancelled a case because I didn't want that patient to pass away under my anaesthetic, even if I could see that there was a condition that they might not survive in the short or even medium term. Let's move on to Ms. TH. She's 35 and she had a head injury. She got a minor cortical scar, which has now given her refractory epilepsy. She's failed to tolerate with a number of medications, and she's got a disabling frequency of seizures. So she's going to have something far different to the lass who was very anxious about having the mole taken off her forearm. She's going to have an awake craniotomy. So we're trying to minimise the damage to her parietal cortex of her brain. So she's going to be awake while the neurosurgeons map where they're doing and how much scar they can excise. And that's a big ask, isn't it? So she's also going to have lines put into an artery. She's going to have a central line put in through her neck or her chest while she's awake, so that we've got all that safety monitoring. She's going to be seated, and she's going to have her scalp anaesthetized, and she's going to have her head bolted into a frame. She's awake. She'll have a little bit of something that's like Valium, so that she can't involuntarily move and cause a problem, which would be a disaster. And we'll be standing there at the ready with anaesthetic agents and muscle relaxants if there is any loss of control. And she's going to be asked to cooperate with that. Sometimes these are quite complicated things and there's very little choice. The other choice for this woman is to have potential loss of speech, motor function, and those sorts of things that could be really mitigated with an awake surgical technique. So in conclusion, I hope that sort of demonstrated that there's often a lot of options, that my choice, if I'm anaesthetising 10 patients in one day, they might range from 2 to 98 years of age with all sorts of different background conditions that I've got to take into account, the surgeon that I'm working with, the length of the procedure, and all sorts of other factors. There might be absolutes. I might be able to factor in patient preference as much as is reasonable. And there might be surgical preferences and requests that might go to and fro. And it's also what's safest in my hands. There are anaesthetics that I have that colleagues might have given for that 2-year-old that would be completely not my choice of medications, but in their hands and with their experience, that's a good technique for them. The main message is that any plan is just a plan, and it's only a short endoscopy or suture or whatever is a famous last word, and you need to be prepared for anything. Thank you.
Well, hello. I do love this meme. It's a good one. Thanks so much, Dr. Tamara Culnane. Really appreciate it. There's certainly a lot of very valuable information, particularly for our lawyer clients who work in the medical negligence space, and for those who are interested in just how an anaesthetist chooses what kind of anaesthetic to give you and why it's different for different types of people. Does anyone have any questions that they would like to ask? If you do, you can pop them in the chat, or you can unmute yourself and ask away. Cool. Usually when there's no
Yes,
questions.
hi there. I've got a question. Michael Short's my name. I'm a partner at Veritas Law Firm. I've got a question, I suppose, to just want to raise about issues of cannulation, I suppose, and about injuries caused not so much with the actual anaesthetic medication, so much as an incorrect cannulation of the and what steps does the anaesthetist, or what is it in a perfect world? What ideally should an anaesthetist do to ensure that when the cannula is inserted, it's inserted correctly before the administration of the anaesthetic?
Okay, so yeah, I mean, that comes down to the choice of the vein, qualifying that with the fact that often your choice of vein might be limited in terms of age, skin, venous quality, and so on. And so your choice of vein in the first sense, ideally a vein that you can see and that you can see some tissue proximally or towards the body away from your cannula, so you can see any swelling or tissuing or changes there. Sometimes you've got no choice and you've got to put the vein that dripped right in the elbow. That's usually pretty safe, but with flexion that could move or displace. And sometimes when I'm cannulating small children who are well covered, I'm basically doing blind cannulation based on my knowledge of anatomy and the likelihood that there'll be a vein between the third and fourth metacarpal here, or this or that, or the saphenous vein on the ankle will be here between this and that point in most. So qualifying it with, sometimes you've got difficult veins to deal with. Choice of a vein in a place that ideally you can see and that you can see during the surgery. So ideally, if they've got both arms strapped next to them, sometimes for neurosurgical procedures, we'll put a drip in the foot when they're asleep, so we can move to there because we can see the foot, we can see whether that drip's functioning. Aspirating or flushing it after you've placed it is a good practice, because you can say, well, that freely flushed and I'm quite comfortable with that, with just some saline, which is non-toxic. If it goes in the wrong place, it's not a problem. But other than that, it's just surveillance. I mean, as you note, you can cause injuries. You could cause a little bit of cutaneous nerve irritation, and people can have irritation that usually just goes away, but sometimes can be quite persistent and troubling. Occasionally, a cannula will fracture, and the cannula has a central metal trocar, and the plastic cannula is outside of that. So you pierce that into the vein and then push that plastic in, remove the needle. Now, it's possible, if you're moving about trying to find the point, that the tip of your needle can fracture the end of the plastic, and then you can either damage the vein or, in the worst case, maybe leave a foreign body behind that will have to be removed. Neuritis, yeah. And look, usually that is, it's going to be either mechanical from actually, puncturing or glancing past or through a little nerve, or it's going to be a matter of extravasation. It can also be from a cannula just lying on or causing pressure on a nerve if it's there for a period of time. And that does happen. It's a recognised complication. It's pretty hard to predict that, because you're not going to generally get any complaint on insertion that tells you that that's any different from having the cannula, any discomfort from having the cannula placed, which is normal. So it's a difficult thing, but basically reassessment, vigilance, watching, rechecking your cannula, and watching how your drip's running, watching the tissue for any expansion, which might signify that the fluid's going outside of the blood vessel. It's just vigilance. And, I think it's best practice to ideally flush a cannula before you then put your induction drug in.
Is that, I'm sorry, I don't want to interrupt. Is that flushing of the cannula, would that identify that it hadn't, say, gone into the vein because of there'd be no flow back?
Yeah, and generally what you're actually doing is you've got, say, a sterile saline in a syringe, and you're pushing it through, and you're actually feeling whether the compliance is easy. and it feels easy.
Understood.
Yeah.
Yeah, I have a case. I know, so I don't want to get into the specifics of it. It's a gentleman who was cannulated incorrectly, and they inserted some anaesthetic, and he has suffered permanent injury to his arm. And really, the issue is to whether there were reasonable steps that could or should have been taken to identify that the cannula was intramuscular rather than intravenous before the insertion of the anaesthetic.
Yeah, and look, it's about feeling the compliance as you inject anything, and the second thing is whether that cannula was placed correctly but then displaced. And if you're transferring a patient, for instance, from an anaesthetic room,
yes,
or moving them during the procedure, you need to recheck, is your cannula patent? And a cannula will often run a little bit into soft tissue, and unless you're very diligent at feeling whether you think that injection is compliant or not, you can early on in an injection think this is fine.
yes.
But it is a matter of just
if you'd like to pursue this one a little bit further, I'd suggest that you email the details. If you want to if you'd like to send an email to medneg, MEDNEG, at Medico-Legal Assessments Group.com.au and mark it for attention, Dr. Tamara, we can get a preliminary opinion organised for you. I'm just going to move on to the other questions.
Exactly, I appreciate that. No, thank you very much, Doctor. You've been most helpful.
No worries. Now, one of the other questions is what influences why someone might need a higher amount of local anaesthetic to be numbed compared to an average person?
The bell distribution of local anaesthetic to be numbed is actually pretty narrow. So I guess for mine, I must say that I don't think there's a whole lot of evidence for big population distribution like there is for the general anaesthetics in terms of response. So most people with a certain given standard volume, limited by their weight in terms of toxicity, if that's infiltrated, you will be able to get them numb. Very occasionally there are problems with batches of local anaesthetic that seem to be not so great. A couple of years ago, there was some a thing called spinal marcaine, which was sent back to a company. A batch was sent back to a company. But mostly there's a fairly narrow distribution. Now, the question with that is whether it's the choice of local anaesthetic and the actual amount administered appropriate to the area. But without sort of knowing that, it's hard to speculate.
All right. Now we have another question. We get a lot of inquiries about injuries arising from epidurals during childbirth. There seems to be varying view as to whether the spinal cord can be injured as the result of an epidural or spinal block. Can you provide some information about this topic?
Oh, it can be injured. It's very well recognised that there is a potential for injury. It's small, but it's significant. And you can do that mechanically. You can have an epidural catheter. It's a blind technique. You insert it centrally through your big trocar, and then you have connective tissue in the epidural space outside the spinal fluid space. Little septa of connective tissue that can cause your little plastic catheter to decide to go to the left or the right, and it might decide to go and sit on the edge of a particular nerve root. Now, that may not be felt or recognised at the time, but it's sitting there and it's a high concentration of local anaesthetic, very, very focally on that particular nerve root. And so you might have some delayed recovery there, or a thing we call neuropraxia, which is just basically temporary nerve injury without the nerve being cut or interrupted. So that can definitely happen. Definitely, in theory, you could instrument the spinal cord itself, but that would be, I would think that would be quite rare. You are using what's called a loss of resistance technique to feel where you are, and you're also going to see cerebrospinal fluid if you're in the spinal space. One of the ways that the spinal cord can be injured from an epidural is from bleeding. You've got normal blood vessels there, and in fact, in the pregnant state, they're actually more dilated than otherwise, and they're the normal blood vessels that are there. And if you nick one of those, it's a recognised complication. Often, as we're looking for our space, we'll see blood and we'll go, oh, and we'll remove and go and reinsert our epidural at another space. And that's been proven to be quite a safe thing to do. But there is the potential, and this is, I guess, particularly in people who might be having an epidural for something like a joint replacement, where they will be having anticoagulants whilst they've got the epidural in, which will then be stopped for a period before you remove the epidural. There are all sorts of protocols to try and deal with thin blood and a catheter that might rub on or nick a nerve, nick a blood vessel. So definitely it's possible to cause an epidural. It's a recognised complication. I will say that I spent many years consenting people for labour epidurals, and always they've been given some information, one would hope, and we're told, in their antenatal classes. They're also given an information sheet, again, and some discussion when they come in, discussion generally with their obstetrician. They're given information when they come into a labour ward. I'm going to say that categorically that's most often would not be read, because you're in there, you're excited or worried, someone's looking after your other child, you're about to do, people don't tend to read that information. And so that when I come, when they are in extremis with troubling contractions, and I am consenting them at the bedside in between those contractions, it's one of those problematic areas of consent. And you then sit down with them after you've inserted the epidural and they're suddenly comfortable, and go, now, just again, I want you to read the sheet now and just make sure if there's anything, because, and that's sort of partially post-consent, but in that situation, it's very difficult for everyone to remember everything they've been told.
Yeah. There's a follow-up question here, and that we'll make that the last question, because I'm conscious we have gone a bit over time. And that was further to the previous question about caesarean section and epidurals. Is there a link between epidural poor management of pain and pelvic floor dysfunction after a caesarean section?
Look, I'd say in a sense of biological plausibility, I'd say no. If you're talking about an epidural that has failed or given minimal analgesia, and you're wondering if there's been a little bit of less relaxation of the pelvic floor at the time of, first and second stage delivery in particular, I'd say it's a doubtful thing. I mean, certainly I do know that when a lady having an instrumental delivery, so perhaps a forceps or suction delivery vaginally, has to come to theatre for that, then obstetricians that I've worked with would prefer a spinal block if possible, or a quite dense epidural block, because there is some additional muscle relaxation over and above a light epidural. But it is more in terms of the ease of the procedure than, I probably would, to say more on that, I'd probably speak to an obstetrician about what their feeling is. Yeah.
Thank you so much, Tam. Really, really great. Even I learned stuff, and I've known you for ages. There's a couple of thank yous in the chat. I know that this was actually a really successful talk. Thank you very much. And thank you to everyone else who gave you time to listen today. I hope that you share this with your colleagues, and of course watch this and our other seminars on our YouTube channel. And of course, you know that if you email medneg@medico medico-legalassessmentsgroup.com.au, you can access Dr. Tamara Culnane for an opinion on your matters. Thanks so much, everybody, and have a great rest of the day.